why this is happening. Okay. Yeah, so the correct answer is subjective, objective, assessment, and plan. Basically, this question refers to the case history that we take, that the mnemonic for remembering that is SOAP note. So we are supposed to assess the patient subjectively, meaning to say, when we talk to the patient, when we take their history part, the medical history, dental history, and all that. Objective is when we do the examination of the patient, and then assessment includes the diagnosis that we are framing and also the differential diagnosis, and then we give a treatment plan. Okay, any idea what is suction, oxygen, airway positioning? Very good. Emergency management, this is typically for intubation. If there is a patient for whom we have to do an intubation, for whom an intubation has to be done, then they use the equipment that is to be ready, is to be done in this order: the suction equipment, oxygen equipment, like that it is. Okay, the airway, breathing, and respiration, that emergency management, that ABC, that is slightly different. Okay, the other two options are just dummy options. Second question. What does zoster sign herpetae refer to? BB. I got 3 B's. Confused between B and D. Okay, only pain, no lesion. That is the correct answer. Only pain, no lesion. That is C. Okay, so you all know herpes zoster is caused by the varicella zoster virus. Can anyone tell me what is the primary infection caused by varicella zoster virus? Correct. Chickenpox. Correct. So chickenpox is the primary infection. After chickenpox resolves, the virus goes to the ganglion of the nerve. And from there, when there is a suitable circumstance, for example, the host for some reason is immunocompromised or has fever, something like that also, the virus travels down the nerve pathway, reaches the epithelium and causes lesions. And those are called as herpes zoster lesions. Okay. So we'll go through each of these and then we'll look at why this is correct. So there is nothing called herpes zoster of the finger. It is actually the herpetic whitlow that has nothing to do with zoster. So this is just a dummy choice. Varicella zoster infection, all of these are varicella zoster infections only. Both chickenpox as well as herpes zoster are caused by the varicella zoster virus. So this is again a vague term only. Post-herpetic neuralgia is neuralgia or pain along the path of the nerve that develops, that lasts for about 3 to 6 months after the lesions have healed. That is called as post-herpetic neuralgia. Now, there are some patients in whom what happens, we know that herpes zoster is characterized by an acute pain, isn't it? It is characterized by severe pain along the course of the nerve, following which there is development of vesicles. Something like this in a dermatomal pattern. This is very, very typical for a herpes zoster infection. Along the entire dermatome, there are multiple. Elsewhere in the body, you will not find anything. And of course, it is unilateral. So these are the vesicles. Vesicles, you remember, are fluid-filled blisters which are less than 1 centimeter in diameter. So these are the vesicles that we see in herpes zoster. In some patients, what happens, these vesicles or these kind of lesions don't develop. There is only severe pain that is present. Okay, so this is important for us dentists because there might be situations where the trigeminal nerve might get affected. Patient will come to us with severe pain, but there are as of yet no vesicles at all present. So we won't know the cause of the pain of the patient. So that is why that term zoster sine herpetae is important. That was given to describe a condition where their patient has severe pain, but there are no lesions. I hope this is clear. Okay, I'll move on to the next question. All the following drugs may cause lichenoid reaction, except which one? Correct. I got 3 Ds and 1 C answers. Right. So let's look at each of these conditions. So what is a lichenoid reaction? Basically, lichenoid reaction is something which is clinically and histologically similar to lichen planus. So lichen planus, consists of striae in the oral cavity, white striae, which are called as Wickham striae. Whereas a reaction is a lichenoid reaction. It is different from lichen planus in that there is some particular cause for it. For example, a drug use, or for example, a large restoration or something like that. Okay, so that will that will cause this kind of a reaction, which is, I'll just show you the image also. The correct answer in this case is clobetasol. Okay, let us discuss this. So like I was telling, lichenoid reaction is a condition which is differentiated from oral lichen planus in the fact in two things. First and foremost, oral lichen planus is always bilateral. So you will look for lesion on both left and right side, whereas lichenoid reaction is always unilateral. Second point to remember, lichen planus is a more chronic condition. It will not go away with a simple medication or anything like that. Whereas in lichenoid reaction, if we determine the cause, for example, a drug which is causing the lichenoid reaction or an amalgam restoration or some such material which is causing the reaction, as soon as you remove that particular irritant, then the reaction will heal completely. So that is the two differences between lichen planus and lichenoid reaction. So there are many, many drugs actually which can cause a lichenoid reaction. These are of course taken systemically, but the response is there in the oral cavity. So some of these drugs are antimalarials, the quinone drugs, sulfonamide, metronidazole, and metronidazole. Clobetasol is a corticosteroid which is used in the treatment of lichenoid reaction and lichen planus. So definitely it is not a causative agent. Okay. So one more thing about sulfonamide I'd like to mention is that it is another drug which has a high potency to cause erythema multiforme. Just remember that one point also. So this is what a lichenoid reaction looks like. So this is actually not a drug-induced lichenoid reaction, rather it is a contact lichenoid. So this is a huge amalgam restoration here, and this patient has developed the reaction in response to this. So this is lichenoid, it is unilateral, and you can see this peripheral area and all are showing multiple line-like appearance. So next question, 3 centimeter squamous cell carcinoma of the reticular trigone and invading the mandible and the medial pterygoid muscle is at what TNM stage? Correct. Correct. Very good. Yes. So answer is stage 4. That is correct. We'll just look at the various TNM stages. So basically, yeah. So stage 4 is the correct answer. So if you look at the T staging, T1, T2, T3, and T4, T4A, T4B is there. Let's remember T4. So T1 is less than 2 centimeter, 2 and 4, the numbers to be remembered. T1 is less than 2 centimeter, T2 is 2 to 4 centimeter, T3 is more than 4 centimeter, and T4, like one of you said, it is an invading type, larger than 4 centimeter and invading into either the mandible, the maxillary sinus, the muscles, adjoining muscles, or the skin. So one of these involvement, when it is invading, it is called as T4. N staging, you have to remember the numbers 3 and 6. N1 is a single node less than 3 centimeter. N2 is divided into N2A, 2B, and 2C. 2A is more than 3 centimeter, less than 6 centimeter, single node. 2B is two nodes, multiple nodes on one side. 2C is ipsilateral side, so not ipsilateral, contralateral or bilateral node, less than 6 centimeter. N2 is referring to nodes which are between 3 and 6 centimeters in the greatest diameter. N3 is nodes that are greater than 6 centimeter diameter. I hope I didn't confuse you. This is what you've read. I just went over the thing again. I'd just like you to remember this particular table for staging, which I find very useful. So this yellow represents stage 1. So T1 N0 is stage 1. Okay, there is just a very small component. So T1 means less than 2 centimeters. So this is stage 1. Stage 2 is this orange. So T2 N0. As soon as a single node becomes positive, becomes metastatic, straight away it goes to stage 3. So this green is all stage 3. So T1 N1, T2 N1, or T3 N0 and T3 N1 are all stage 3. And as soon as you go to T4, it becomes stage 4. So all the red represents the stage 4. So this is a staging. Also, from a surgical point of view, actually TNM staging is more relevant than the staging of the stage 1, stage 2. Compared to that, TNM, if you have the individual component, they are better assessors. Okay, so go on to the next question. Bimanual palpation technique is carried out for yeah, correct, correct. Okay, right. So it is, like you all said, it is carried out for the submandibular gland. So now the submandibular gland, it is a gland that is present just posterior to the mylohyoid muscle, isn't it? So we need to palpate it using both our hands. What is meant by bimanual palpation technique is where we would use both our hands. One hand is placed intraorally and one hand is placed below the chin like this. So this is the way we palpate the submandibular gland. The other glands, the sublingual gland, is in the floor of the mouth. So it's actually more of, a collection of the acini and all that. So it isn't really palpable as such. Ranula is definitely visible in the oral cavity itself. Cervical lymph nodes, we do not use any bimanual palpation. It is just a single hand that we use for palpating for cervical lymph nodes. What is this called? This is called as bidigital palpation. Bidigital is where you use two fingers. Bimanual, two hands. Bidigital, two fingers. Okay. Next question. Drug of choice for xerostomia is good. Pilocarpine. Correct. So yeah. So codeine causes dryness of the mouth. Atropine is parasympatholytic, so definitely it causes dryness. Pilocarpine is the drug which is a parasympathomimetic drug which induces salivary secretion. So pilocarpine is the answer. Clotrimazole is an antifungal drug. Just put there to confuse you people. Yeah, correct. Parasympathomimic tone. Correct. I'll move on to the next question. All these conditions are associated with diffuse melanotic oral pigmentation except Addison's disease, Cushing's syndrome, hyperthyroidism, hyperparathyroidism. Look at the choices carefully and tell me. Okay. Okay, so I think you saw the answer. It was hyperparathyroidism. 1 minute. Yeah, okay. Right. Okay, so that's why I said just look at all the options carefully. So Addison's disease is a condition where the steroid levels are decreased, isn't it? So when steroid levels are decreased, it is because the ACTH is secreted more. So Addison's is typically associated with diffuse melanotic oral pigmentation. That is perfectly right. But in Cushing syndrome, in some instances, what happens? Cushing syndrome is a condition where steroid levels are increasing. In some instances, it could be because the ACTH level is also high. The ACTH secretion itself is high, and that is why the steroid level is high. So in such conditions, it is called as it can cause diffuse melanotic oral pigmentation. In hyperthyroidism, what happens is that there is the blood vessels in the oral cavity or underneath the epithelium, they're very thinned out. Okay, because of the thinning of the epithelium, there is an irritation to the melanotic the melanocytes that are present in the epithelium, and they can produce more of melanin and cause pigmentation. So that is the reason why hyperthyroidism there is pigmentation. Whereas in hypoparathyroidism is not associated with any melanotic pigmentation. It is associated with hemosiderin pigmentation, but not melanotic pigmentation. I'll just show you some pictures. Yeah. So why ACTH is because ACTH is produced from the precursor hormone called as pro-opiomelanocortin. So pro-opiomelanocortin also contains the MSH as well as ACTH. Whenever there is an increased production of ACTH, MSH is also going to be increased. MSH is melanocyte stimulating hormone. So whenever ACTH, in all conditions where ACTH is increased, MSH is also increased. Just remember that much. So for this question, actually I only formulated out of from the textbook, not taken from any previous year's papers and all. So it might have been a bit confusing for you. Purposely, I wanted to give it something like that because I want you to look at all the choices. So this is just a clinical presentation of what the diffuse pigmentation. Is this clear? Any doubts with this? Okay. Next question. Candida infection is not seen in which of these conditions? Okay. Somebody asked for a repeat of the previous question. I'll just go back to it. I'll finish this question and then go back to it. Okay, so let's look at the choices. Candida infection is not seen in median rhomboid glossitis. So median rhomboid glossitis, we hear about the tuberculum impar and all that thing. All that is not accepted now. It is a candida associated condition where on the dorsum of the tongue you find a rhomboid patch. Geographic tongue is more of a dermatological sort of, it's associated with psoriasis. So it's not at all associated with the candida, like you all said. That is the correct answer. Oral thrush is another synonym for candidiasis, and denture stomatitis. Yeah, so here is the picture. So this is oral thrush where you have scrapable white lesions, isn't it? You can just scrape off all these white areas. So this is candidiasis, typical candidiasis. This is geographic tongue where you have these white lines that are present and areas of deep appellation. Denture stomatitis, you can see how neatly the area where the denture was covering, in that area, especially where there's a poor oral hygiene maintenance and all that, patient will develop a candidal infection under the maxillary denture. This is median rhomboid glossitis, where there is loss of the filiform papillae in the center of the dorsum of tongue. So it is characteristic of, again, it is a candida associated lesion. So it is caused by candida. Okay, so I hope that clarifies. So coming back to this, just a previous question, going over it, Addison's disease basically is characterized by a decrease in the level of, what is Addison's disease? Deficiency of the steroid hormones. Why there is deficiency is because of the feedback mechanism. When the ACTH secretion is more, this steroid levels actually shuts down. It tries to tell the ACTH, stop it, don't secrete and all. But there is some problem with the pituitary, and ACTH keeps on getting secreted. So when ACTH is more, MSH is more, pigmentation is more. That's all. So that is about Addison's. This is very typical for Addison's and a classic example for a oral melanotic pigmentation. In Cushing syndrome, not in all cases, but in some cases of Cushing syndrome are due to a excessive production of ACTH from the pituitary gland. So when that happens, when ACTH is the cause, then that is also associated with pigmentation. Okay. Hyperthyroidism, I was telling you, is a condition where there can be, not in all patients, but there can be a melanotic pigmentation because of the weak vasculature that is present in these patients. So when you're given these kind of choices, just look at the options. Hyperparathyroidism is no way associated with melanin pigmentation. So it is the safest bet here. So looking at all this, which all can cause melanotic pigmentation, like that you have to think any connection with MSH, then it might cause a pigmentation. Otherwise, they don't. I hope that clarifies. Somebody asked for a repeat. Vagisha, I hope it clarifies. Yeah. So I'll continue. These are the tongue lesions we saw. Next, hit and run hypothesis. What does that explain? Two answers. Others? Not sure, is it? Okay. Yes, good actually. A is the correct answer. Okay, what is meant by this hit and run hypothesis? Okay, so this is the hypothesis and the explanation of oral cancer. So what of all the etiologies of oral cancer, we know that the most common etiology is tobacco and all carcinogenic agents and all that. So alcohol and all that, right? So that is, so one etiology in patients who do not have any habit history at all. And also, especially in oropharyngeal cancers, the role of HPV is found to be very, very prominent, human papilloma virus. So the people harboring this virus are said to be predisposed to developing cancers, posterior tongue and oropharynx. That is the most common location for these people. So what does this virus do? We all know that in carcinogenesis, there are two stages. One stage is called initiation and the second one is called promotion. So initiation is where where there is a single mutation. That is how the cancer actually begins. And then promotion is where over a period of time, all the genetic events keep adding up together and result in the formation of a cancer. So that initiation is done by this HPV. So somewhere it starts off with that the initiation of the cancer. Okay, but afterwards, if we try to look for the virus, let's say we're looking for viral particles, we don't find the viral particles in the cancer itself. So that is how they proposed and said that it hits the cells and then it disappears somewhere because we are not able to detect it. So that's the reason they gave the hypothesis called as hit and run hypothesis. Okay, let's just go over the other choices. Condylar fracture secondary to trauma to chin. Just added up all these things. That's all. So when there is trauma to the chin, the forces are transmitted to the condylar region, and very frequently we see unilateral, sometimes bilateral condylar fractures. So what is this cardiac anomalies due to streptococcus? So this is nothing but our rheumatic heart disease, where they say that the streptococcus licks the joint and bites the heart, isn't it? That's the term we should remember. Licks the joint, it causes the joint pains and all that. But the more problematic thing is where it causes the valvular heart disease. It could cause mitral stenosis, mitral regurgitation, tricuspid regurgitation, and all those things. So that is the cardiac anomalies. Dislocation of the mandible, I just put it, maybe like thinking of a trauma. So that is a thing. Okay. Shyam, I just explained it. Did you understand what is hit and run? Should I repeat? No, should I repeat again? Okay, fine. Frey syndrome occurs due to injury during which procedure? Very quick on this. Yes, good. Correct. So all of you have said B, that is the correct answer. And that is due to trauma to the auricular temporal nerve. So this is somewhat like this. So what happens is, if this is the auricular temporal nerve, if there is injury and or if there is some surgery, parotid gland surgery, then there is re-innervation of the sympathetic nerve. So this parasympathetic nerve, it goes and re-innervates the skin overlying the parotid gland. So what happens is that when a person has Frey syndrome, when he's going to eat something. Okay, there is parasympathetic stimulation. So there is secretion from the parotid gland. That is a normal thing that happens. But in such a patient with a Frey syndrome, what happens? There is also stimulation of the sweat glands on the skin over the parotid gland, and the patient develops redness and sweating of the area of the skin above this gland. How do we detect this sweating? You apply some iodine over it. Okay, some iodine is to be applied on the face in this region, and then spread starch powder onto this. So when we spread starch, the sweat reacts with the iodine and converts the starch into a brown color. So if you see a brownish color discoloration after application of starch, then it is a positive confirmation that it is a sweating that is happening, and it's because of the Frey syndrome. Okay. So I'll go on to the next question. A 56-year-old diabetic male patient presents with a sudden onset of deep palatal ulceration and proptosis. What is the possible diagnosis? some B's and some C's. Okay, let's look at some points in this, important things to note in this question. Then we will see. Good, nice attempt you've made. And yeah, we'll continue. So I just want to point out a few important points that we need to keep in such a situation. So this is a middle-aged, slightly elderly patient who is known diabetic. That is one important point. Second, sudden onset. Sudden onset is there. Okay, that is important. Deep palatal ulceration. So the classic finding here is palatal ulceration and proptosis. Proptosis is where the eyeball is pushed outwards, right? Okay, so which is the condition that causes all these things? Carcinoma palate. Now, carcinoma palate in an elderly male patient, it is more probable to occur. But here, sudden onset will not go in with a carcinoma palate. It is more of, slightly more gradual. Sudden increase in size might occur, but it will not be a sudden onset. Necrotizing xylometaplasia. Necrotizing xylometaplasia, you all know it's a salivary gland disorder where there is ulceration in the palate. Perfect. But it has a slightly, it doesn't have a sudden onset. It has a slightly insidious onset. There is destruction, there is an ulceration over the palate with exposure of the palatal bone can also occur. But I have never heard of that leading to proptosis. Okay, proptosis here is important. So why there is proptosis and we are relating it to this? It means that there is some lesion which has gone into the palate and gone somewhere near the eyeball and it's actually pushing the eyeball outwards. That kind of growth will not happen with necrotizing xylometaplasia, isn't it? Necrotizing xylometaplasia just causes necrosis in that area of the palate. It will not spread out onto the eyeball region. So that is not the right answer. Syphilitic gamma, nobody answered. Anyway, that is correct. Syphilitic gamma occurs in the tertiary stage of syphilis, where we see an ulceration in the palate. So again, there's nothing to spread there. So what is mucormycosis? Mucormycosis is a fungal infection that is caused by a fungus belonging to the mucorale family. Okay, so this is the classic features for mucormycosis that you need to remember is that there has to be some predisposing factor, and the most common predisposing factor is uncontrolled diabetes. So whenever they say uncontrolled diabetes, deep palatal ulceration, these two things are coming. Please keep mucormycosis in your mind, because although it is an extremely rare condition, when these two are put together, definitely one of the causes could be a mucormycosis. And mucormycosis is quite an invasive fungus. Okay, so it spreads into it is called as rhinomaxillary mucormycosis because it spreads through the maxilla, reaches the eyeball and pushes the eyeball outwards. So the answer is mucormycosis, and I have some images here for you. So this is carcinoma palate. I hope you're able to see. So this is a proliferative growth that we are seeing here in the palate. This is a necrotizing xylometaplasia. So as you can see, there is a necrosis and there is an ulceration of the palate with some exposure of the palatal bone and all that, but it will never go spread deeply. So gamma, very clean, neat destruction of the palate, which is perforated through the palate. So this is again classic feature of syphilitic gamma. This is a case of mucormycosis. So you're able to see the necrotic area, huge ulcer with that necrosis, and typically they have a very rapid onset. Within just 2 to 3 days, suddenly it will be a very small thing, and within 2 to 3 days, the patient will have communication between the oral and the nasal cavities and maxillary sinus and all. It will go spread very rapidly, and this is the proptosis that this patient has developed. Okay, does that answer your questions? I hope this is clear. I'll go on to the next question. Which of the following is recommended in the management of oral mucositis? Okay. 1 minute. Kaustav is asking a question. Is the previous question related some doubt? I'll come back to it. Okay. I'll finish this question and then I'll come back to it. Okay. I'll finish this question as of now. So most of you have answered D, benzidamine mouthwash. Okay. So first of all, what is oral mucositis? Oral mucositis is a reaction in the oral mucosa to either chemotherapy or radiotherapy. So yes, actually last time when we discussed radiology, we were talking about the cells which are most radiosensitive and all that. It applies to chemotherapy also. Even chemotherapy and radiotherapy, the cells that are continuously dividing are the ones which are most affected. So as we know in the oral mucosa, there will be continuously dividing cells. So oral mucosa is very, very sensitive to all these things. So patients develop, severe large ulcerations. They won't be able to eat and all that stuff. So this is I just show you the classification also of oral mucositis. Just 1 minute later. Okay. For that, what is the medication that we use? Sucralfate is basically a drug which forms a layer, which forms a covering over any ulcerations. It is typically indicated for gastric ulcers and duodenal ulcers and all that. But several studies have found that it is not useful in case of oral ulcers. In case of oral mucositis, sucralfate has not been found to be helpful. Pilocarpine, like you all told me, is a parasympathomimetic drug which is going to increase salivary secretion. So that has nothing to do with oral mucositis. We need something that is going to heal the epithelium, the oral epithelium. So pilocarpine will not help. Chlorhexidine can prevent infections, but it will still be an irritant to the raw mucosa. So nowadays we advise not even to administer chlorhexidine mouthwash at all. Benzidamine is a topical anesthetic analgesic medication. So that is what brings a lot of relief to these patients. The healing, it takes by itself, it takes its own time. Like after radiotherapy or chemotherapy, once the entire therapy ends, another 2 weeks or so later only, the mucosa will heal on its own. Benzidamine provides us a symptomatic relief from this condition. So it is basically relief. It is not something that is going to treat the condition, but it is going to provide relief. Okay, and it is recommended in the management of oral mucositis. Just added this point for oral mucositis assessment scale. This is called, where oral mucositis is classified as mild, moderate, severe, and life-threatening also. So mild is where there is oral soreness and erythema. Moderate is where there is erythema and some ulcers, and patient can still have a solid diet. This is based on the diet that the patients are taking. In stage grade 3, they're able to take only a liquid diet, and stage 4 is grade 4 is so severe that you'll have to give an IV nutrition itself. They will not be able to tolerate anything at all. Okay, I hope this is clear. And to answer Kostav's question, so you asked me about proptosis, right? So proptosis, classic example. Can you tell me bilateral proptosis? Can anyone tell me what is the classic example? Yes, Graves' disease. Actually, when I was a student, to open that picture where that Graves' disease का thing was there, I used to डर लगता था, because I used to think क्या है ये आँख कैसा है इतना बड़ा बड़ा दिख रहा है नहीं. So classic example is Graves' disease. One more very common important example from dental point of view that you need to remember is cavernous sinus thrombosis. Cavernous sinus thrombosis. Cavernous sinus thrombosis, especially unilaterally, it's called as pulsating exophthalmos. Okay, what happens in cavernous sinus thrombosis? One eye will be proptosed and it will be pulsating like you. Okay, it will be like like सामने आगे पीछे ऐसे थोड़ा ना, जैसे with the क्या कहते हैं, with a pulse, it will be moving. So that is typical for a cavernous sinus thrombosis. Graves' disease and the cavernous sinus, I think these two we can remember. Apart from that, there will be other causes like some tumors and like, something in the eye related disorders and all that. As dentists, we don't need to know all those things. So few things we need to remember is mainly Graves' disease is what we. Blow-in fractures, yes, very good. I didn't remember that. Yes, maybe blow-in fractures would also cause proptosis. But then the etiology will be very clear-cut in that case, right? Anything else you can think of? And any other diagram? Sorry, I have not collected any, but I think if you just Google it, you should be able to see a lot more diagrams. You want a few more diagrams related to what were you asking? Is it related to mucormycosis or proptosis? Costa, other diagrams related to what did you want? Okay. Okay, 1 minute. I'll just show you. I'll go back to this pic itself. Yeah. So, uh, so this is another look at the same picture itself. If you want, I'll just find out if I can share any pictures. One eye portion infected right side. How much portion? I didn't understand your question. Cause. Okay, so the cause is, see what happens, it's a fungal disease, right? That's why I told you it is called as rhinomaxillary type of mucormycosis, where the fungus will invade. Okay, it has typical capacity to invade through the palate, goes to the maxillary sinus, breaches the floor of maxillary sinus, and goes into the orbit, okay, inside the orbit, and it will cause the destruction of the tissues over there. So because of all the destruction of the tissues, the eyeball gets pushed outwards. And also you can also see it's become erythematous, and so much of swelling around the eye, periorbital edema, and all that stuff. Features of infection are there. Okay, so that is why you have proptosis. It's because of the invasion of the fungus. Does that answer your question? Medication treatment will be antifungals. These people actually, it's a slightly serious condition. So they need to be treated with antifungal agents. They give amphotericin B. So they usually take them as inpatients, because amphotericin B IV and all, it's given for, if I'm right, something like 4 to 6 weeks, something like that. Continuously therapy has to be given to bring it into control. Earlier, the mortality used to be very high, but they say that now it's slightly improving and all that. As such, it's a pretty rare condition. Okay, so I'll go on now. So we saw this question. We saw the OMR score. Next question. Endocarditis prophylaxis is recommended during the following dental procedures, except for which condition? Somebody typed A. I hope you mean it, because definitely before any procedure which is going to cause any amount of bleeding, then definitely endocarditis prophylaxis is recommended whenever indicated. That is when the cardiac condition indicates it. Okay. So like you all said, the correct answer is initial placement of orthodontic brackets, because it's a bloodless procedure. It's a very simple procedure where we do not breach the epithelium or anything like that. So extractions, definitely we give endocarditis prophylaxis, intracanal endodontic treatment, because we might go beyond the apical foramen and there could be bleeding. So, and that bleeding could lead to bacteremia. The idea is we want to avoid any kind of bacteremia. We all know that there are so many bacteria in the oral cavity and we do not want them to get into the bloodstream. That's the reason we give an endocarditis prophylaxis. Obviously, periodontal procedures causes a bacteremia. Okay, so just added this. I think you will remember it, but just for you to refresh your memory. So we give amoxicillin 2 gram, half 30 to 60 minutes before the procedure is to be done. Just remember that much, and clindamycin 600 mg. I'll go on to the next question. A 45-year-old male presents with sudden onset of inability to close his mouth after wide yawning. He complains of severe pain in front of his ears. What is your diagnosis? Right. So most of you have said A, and yes, that is the correct answer. Dislocation of condyle. Okay. So what is dislocation of condyle? So basically, when the condyle, this is the articular eminence, and this is the mandibular fossa. So when the condyle moves ahead of the articular eminence, it's called as dislocation of the condyle. So this cannot go back all by itself. That is why when the patient presents to us, they present with an open mouth and inability to close the mouth. Okay, you should remember that this is a very distressing condition for the patient. It's very, it's they're so anxious that they're not able to bite, they're not able to close their mouth and all that. Okay, so this patient has actually a unilateral dislocation. So we can actually see this is normal side where the preauricular area appears to be normal, whereas here you can see the hollow where the condyle was present, and we can also see how the condyle has moved front over here. And also here the mouth is closed, whereas on this side there is mouth opening, so the chin is slightly deviated to one side and all that. So that is happening. The second option was, I think, articular disc displacement. Articular disc displacement is when the we have anterior displacement, where there is an articular disc that is present between the condyle and the temporal bone. So if the disc itself gets moved forward, not the condyle, only the disc comes anteriorly, then we call it as articular disc displacement. This is disc displacement with reduction, without reduction. We have two types, which is classically associated with clicking of the joint, okay, during opening and closing. So that's the thing. Okay, one more point here is what do you call a condition where this becomes recurrent? If the dislocation is recurrent and the patient is himself able to place the condyle backwards into its position, what do you call that condition? Was my question clear? Okay, see, I told you, yeah, I'll just repeat the question. In dislocation, what happens? This is the articular eminence, isn't it? This is the bony part, and the condyle would have come in front of it. So I told the patient is very distressed because this condyle cannot go back by itself. You all must have been taught how to manually reduce the condyle. We'll have to manually reduce this condyle and put it back into its position. This cannot be done by the patient. By himself, he cannot do it. Okay. So what if there is a condition where this has happened a number of times, and over a period of time the patient is able to himself take the condyle back into its normal position? What do you call that condition? Yes, Clark procedure is correct. Okay, I'll give you the answer. The answer is subluxation. Daughtry is different, I think. That is why you reduce the articular eminence, isn't it? Daughtry procedure. Okay, please, that you please clarify with the surgery. Anyway, the point I was talking about is subluxation. Please note the difference between these two terms, dislocation and subluxation. Dislocation is when it happens once and the patient is not able to reduce it by himself. Subluxation is where it is recurrent and patient is able to reduce it by himself. Are these two terms clear? Okay, so what do we do in manual reduction? I'm just going to explain that very briefly. So what we do is, how do I explain it? I'm just wondering. Okay, right. See, imagine this. Okay, imagine that you're holding a mandible in front of you. Imagine the patient is sitting in front of you. Your thumbs are inside the oral cavity and on the occlusal surface, just on the buccal surface actually, of the molars, bilaterally on both the sides. Okay. Rest of the fingers are outside the mouth and below the mandible. Okay. So you're literally holding the mandible in both your hands. Okay. And then what you do, you move the mandible downwards, backwards, and then upwards. So this is how it goes. The condyle has to go downwards, backwards, and then upwards. You can actually feel that resistance. Okay, you can feel the bone, and you can push it back and then take it back into its normal position. And you ask the patient to close the mandible. Okay, so this is the procedure for manually reducing this dislocation. Okay, I don't know if I was able to do justice to the explanation actually. And one more thing is that this is best done when the dislocation is recent. Okay, downward, backward, and upward is correct. Okay, it's to be done in the recent, like when the patient has recently been dislocated, then we can do it. If it's been a period of time, like a day or something like that, the muscles would have become very taut and all that. Then you'll have to give a relaxant, reduce the muscles and all that, and then bring it to positions. That'll have to be a slightly different procedure. This is only when it is recently dislocated. Okay, good, nice. So we'll go to the next question. Which of these is characterized by unilateral periorbital pain, which repeats once a day at the same time for several weeks and is associated with ipsilateral conjunctivitis and restlessness? Very good. Very good. Correct. C is the correct answer. Cluster headache. Okay. Okay. So characteristic features of cluster headache is that it is unilateral, there is periorbital pain, and it repeats at the same time. This is the characteristic feature for cluster headache for several weeks. For several weeks represents a cluster. So there is a cluster of pain for continuously for a few weeks, and then the same thing will repeat next year or a year after that or something like that. That's why it's called as a cluster headache. And it's associated with ipsilateral conjunctivitis, that is tearing in the eye on the same side, and restlessness. These people are restless. This is opposite of what we see in migraine. In migraine, usually people do not want to be, there is that phonophobia and photophobia. So they will be scared of that light and sound and all that. They want to just lie down in a very quiet place on that. So this is not a feature of migraine, which is also characterized by unilateral headache. What's trigeminal neuralgia V1? How do you differentiate it? Trigeminal neuralgia is characterized by paroxysmal pain, right? So pain is of a very short duration, and things like this conjunctivitis, that tearing of the eye, all that thing will not happen in trigeminal neuralgia, and it will be there throughout the day. Temporal arteritis is a condition where there is tenderness over this superficial temporal artery region. In the temporal region, the patient will have, some pain in that area and all that. Okay, when they touch that area, it is a superficial kind of a pain. So C-reactive protein and ESR are increased in temporal arteritis. So those 2 points you can remember because they are characteristic for temporal arteritis. Although it's a headache kind of pain, they have laboratory findings in the form of increased C-reactive protein and ESR levels. Okay, good, nice. We'll go to the next question. Cluster headache, right? Oral manifestation of inflammatory bowel disease includes okay, 1C and the 3Ds. Good. Correct answer is D, all of the above. I'll show you the images and again we can discuss it. So what do you mean by inflammatory bowel disease? Inflammatory bowel disease is a condition that is characterized by two conditions. One is ulcerative colitis and the other one is Crohn's disease. Crohn's disease is basically where there is an involvement of any part of the it's a sort of gluten sensitivity. They have an allergy over the entire, it could be the entire GIT starting from mouth till the anus, anywhere they could have the reactions. Whereas ulcerative colitis typically involves a large intestine only. So there is ulceration and there is diarrhea with bleeding. Okay, so that is the characteristic feature. So in either of both these conditions, there are characteristic oral manifestations that we as dentists need to remember, because if we are not able to find a oral cause, then we need to suspect a systemic cause for our patient's condition. So this kind of an appearance, a granular sort of an appearance with, it's a kind of a, it looks like as though it's discharging pus and all that, multiple sinus kind of openings and all that. So this is called as pyostomatitis vegetans. Okay. Aphthous ulcer and a normal aphthous ulcer, which any of us, any of our patients might be getting. Of course, only aphthous ulcer will not lead to that diagnosis. You need to combine with proper medical history and all that. So this is the cobblestone mucosal architecture. The cobblestone is like in the footpath and all, where they put the stones and all, no, one after the other, something like that. So these are all just a different architecture where the oral mucosa is looking abnormal. So always remember, when you see oral mucosa which is looking somewhat abnormal, think of systemic causes which are causing it. Okay. For your entrance point of view, of course, I thought this answer was very easy because all of the above is there. So generally, it's a little easy to answer kind of question. Okay, right. We'll go to the next question. Which of these drugs can be administered to a patient with chronic kidney disease without any change in dosage? Not D. I got all the other options. Some confusion, I think. Lidocaine is local anesthetic. Correct. Easy to answer, no? No, no. In this case, I did not consider the fact that it's like, even you give it systemically and all that stuff. Yeah. Here, out of all these, the idea was to tell you that in all these other medications, lidocaine is the answer, by the way. Sorry. Yeah. Okay. So ibuprofen is the dosage has to be altered. Acetaminophen, again, dosage has to be altered. Amoxicillin, actually ibuprofen, sorry, it is to be avoided in patients with chronic kidney disease. Acetaminophen, amoxicillin, dosage has to be altered. We have to reduce the dosage in case of renal disease. Lidocaine is, of course, I mean, we don't administer it systemically and all that, but of course, for a patient with CKD, if you're doing any dental procedure, you can safely go ahead with administering them with lidocaine. So that was the intention of asking. And one more thing is, like, some of these questions, I just put them myself. So you might find that it's not that typical what you get in your exam and all that. Okay. So next question. 72-year-old person walks in with short shuffling steps. His medical history includes daily medication with levodopa. What condition could he have? Correct. Correct. So Parkinson's disease is the correct answer. So I think you got it from the levodopa, but I also want you to draw your attention to the gait of this patient. Okay. So Parkinson's disease, typically they have short shuffling steps, as though they are not sure of where to put down the next foot and all that. Okay. I'll just show you a pic also. Yeah, something like this, like, they're bent forward and all that, and small steps they'll be putting. Okay. So that's the gait in Parkinsonism. Myasthenia gravis is a condition where there is a weakness of the various muscles. Okay, so that so much so that sometimes it's so severe, especially when the masticatory muscles are involved and all. while having their meals, in between their meal, they might feel so tired that they're not able to even chew the meal properly. Okay, so that to that extent also it might be there. Cerebral atrophy is not really associated with any gait abnormality and all that stuff. It's more associated with dementia. Patients will have dementia. Paraplegia, again, you can have the paraplegic gait where one leg, they'll have to drag that leg along and the other leg circumambulates. It'll move together like this, move forward in a circular way, and then the affected leg is pulled forward. So I just wanted to draw your attention to the gait of these people. And of course, levodopa is used for the treatment of, because there is dopamine reduction in Parkinson's disease. So levodopa is used as a treatment for that. Okay. So if that's clear, we'll go on to the next question. Among pre-malignant oral lesions, which of these statements is true? Leukoplakia should be proved by biopsy. Leukoplakia does not disappear even after cessation of the stimulus. Erythroplakia, plakia. Okay. So C. Right. Okay. Yeah. Correct answer is C. But let's look at the other option. Why should leukoplakia not be proved by a biopsy? For everything, there is a histopathological diagnosis, no? Yes. Yes. So the term leukoplakia or a white patch is a clinical diagnosis term. It does not have any histological correlation at all. So if somebody does a biopsy for, we do a biopsy for leukoplakia, but not to prove that it's a leukoplakia, but to see whether there's any epithelial dysplasia. Just wanted to correlate those 2 points. So when there is leukoplakia, we look for the grade of epithelial dysplasia. So leukoplakia does disappear, it does decrease in most instances after cessation of smoking or like in India, the smokeless tobacco use and all that stuff. And erythroplakia has a higher risk of malignancy than leukoplakia because it is thought that erythroplakia, the epithelium is thinner. So whatever irritant that is there, for example, the tobacco or anything, it has a higher chance to penetrate into the deeper layers of epithelium. That is why it has a higher risk for malignancy than leukoplakia. And OSMF is typically seen in Southeast Asia and India and the surrounding areas where areca nut is chewed. Okay. Yeah, clinically diagnosed and non-scrapable lesion. Correct. Of all the leukoplakias, which type of leukoplakia has a high malignant potential? This is off the blue. I just remember this question. PVL, correct. Correct. PVL, that's proliferative verrucous leukoplakia. And also, suppose that choice is not there, then speckle leukoplakia, erythroleukoplakia, if that is there. Okay. PVL has the highest tendency for malignant transformation. Agreed. Right. Go to the next question. Which one of the following is seen in facial palsy? Okay. So everyone has said B, but why not A? Can it cause drooping of the eyelid? Okay, so this is the answer that I had got. Okay, so there is drooping of the eyelid and cannot close the eye. There is loss of muscle tone, right? Hmm. No, no, no. It's the not the eye. It is the drooping of the eyelid. No, no. Yeah, it is a drooping of the eyelid actually. Okay, loss of taste sensation when the chordate tympani, sometimes it's there, but drooping of the eyelid is more characteristic. This is what I read up. Yeah, it's not drooping of the cheek in the sense the mouth is pulled towards one side. Yeah, patient is not able to close the eye is perfectly correct. Yes, there is drooping of the eyelid, and in spite of the drooping of the eyelid, the patient is not able to close the eye. That is the point. Is it satisfactory? I don't know. My opinion is totally different from yours. I was feeling so that's why. Drooping of the eyelid is more characteristic because not all cases you will see, and saliva is no, not all. It's not really associated. General sensation in the neck is not associated. Let's see. Yeah. Okay. 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 What do you call this sign where the eye is not able to close? The characteristic sign that is seen in facial palsy? Bell sign. And what does bell sign mean? Correct. When you retract the upper eyelid, the eyeball goes upwards first. Okay. Yeah. Correct. Low motor neuron type. That's what's correct. Yes. Low motor neuron type where the whole face is affected. The furrowing and all that. Okay. So I had prepared for 20 questions, and I finished my questions here. Uh, I just want to say that today I had mixed up a few questions. Like, I changed my questions slightly. I thought add in a few new things. I really appreciate you all did very, very well. Okay? So I think you're well prepared. I'd really like to see that. Okay. Okay, 1 minute, I'll just repeat. Before that, last time we had a few doubts, so I just thought I'll clarify that about, if you remember, bisphosphonates, we had some doubt, right? Bisphosphonate related osteonecrosis of the jaw. So just got the classification of bisphosphonate. So somebody asked me about the dosage of bisphosphonate that causes. There is no specific dosage that says that, below this level bronze will occur and above this level it will occur and below it will not occur. It's not very specific, but always to be remembered that a higher the dosage and longer the treatment, greater chance of developing osteonecrosis of the jaw. So that is one option. That is one point. Second point, you people asked me about drug holiday. That's actually a very relevant point, because it is said that there is, suppose, these people for osteoporosis, they receive bisphosphonates for something like years together, 3 years, 4 years and all they'll be taking. So let's say a patient has developed a dental problem and we have to do some treatment for them. Okay. Now, this is taking bisphosphonate. We might end up with osteonecrosis. So we want to prevent it. So we go in for what is called as drug holiday. That means that for a certain period of time, for example, something like 3 months, the patient will not take the bisphosphonate. They ask them to stop the medication and then do the dental procedure. Okay. So that is, of course, it's done in consultation with the physician. But even if you do that, even if you give a drug holiday, it is not, you cannot be very certain that osteonecrosis will be prevented. So that is one point about drug holiday. Okay. So bisphosphonate related osteonecrosis is classified into these particular stages. Just made a note of it, where there is no bone exposure, and radiographically there is sclerosis of bone. In stage 1, there is asymptomatic bone exposure. Stage 2, there is bone, this is painless, and stage 1 it is still painless, and stage 2 there is pain, and stage 3 there is bone exposure with pain, with more severe conditions like pathological fracture, extraoral fistula formation, or osteolysis extending to the inferior border of the mandible. So in the initial stages, like, even if there is no bone exposure, there is some infection into bone, we just give an antimicrobial mouthwash to maintain that area itself. Multiple antimicrobial agents can be given if there is pain. So this is what is done. Only in severe cases, if there is sequestrum formation, that removal of sequestra, and this is the prognosis is slightly poor for stage 3 and all. So maintenance of nutritional supplements is all that can be done for these patients. So this is what I found out about bisphosphonate related. Apart from this, any other questions from your side? Yeah, you want me to repeat questions 1 to 3? Okay, just 1 minute. Okay. So what does a SOAP note in patient examination or our case history refer to? So SOAP note refers to subjective, objective, assessment, and plan. This is a mnemonic to remember. So how do we do case history? We take a subjective assessment. So we ask the patient the history of presenting illness and all that stuff. Then objective is where we do the complete examination, inspection, palpation, percussion, and all that. Assessment is where we give a diagnosis and a differential diagnosis. And plan is where we do the treatment plan. This is, in short, it is called as a SOAP note. What does zoster sign herpete refer to? Zoster sign herpete refers to the occurrence of herpes zoster with only pain and no vesiculation, where there's no vesicles that are formed and there is only pain. So patient comes with severe pain along the dermatomal pattern, along the nerve, but no vesicle formation. Something like this. This is the typical vesicle formation that we see in herpes zoster, and these are the vesicles. So before the appearance of these vesicles itself, there will be severe pain. So there are some patients who do not develop vesicles. Those are called as zoster sign herpete. Third question is, all the following drugs may cause lichenoid reaction except. So lichenoid reaction is a reaction that is the appearance of a lesion similar to lichen planus, that is a white lesion with Wickham's striae, but two differentiating features. Lichen planus is bilateral, lichenoid reaction is unilateral. As soon as we remove the etiologic agent, lichenoid reaction will heal, whereas lichen planus will not immediately heal. So the drug that causes lichenoid reaction includes antimalarial, sulfonamide, all of them can cause, except clobetasol, which is a steroid drug, which is used in the treatment of lichenoid reaction and lichen planus. So definitely it does not cause lichenoid reaction. So this is a photograph of a patient with It's actually not drug induced, it's rather it's a contact lichenoid reaction. Due to this large amalgam restoration, they have this lichenoid reaction over here. So that those were the 3 questions. Does that answer your doubt? Yeah. Okay. One more point I just remembered about mucormycosis, but this is pretty recent in the sense, in our various some groups and all that in our oral medicine groups and all, we're getting reports and articles where people are saying that because of COVID, when someone is hospitalized, they are under steroid treatment. So they're giving a lot of steroids. And because of the steroids, some of these patients are developing diabetes. And because of diabetes, I believe there are case reports of increased mucormycosis. Okay, so I had one of my classmates also who sent some patients' photos and all saying that they developed mucormycosis secondary to developing diabetes because of COVID infection. Okay, so this is a recent thing that is, I've not seen any scientific articles about this, but just remember this one point because it's a new point. Any questions from your side now? Okay. So if there are no questions, thank you all for joining. I really want to appreciate you're all really well prepared. I wish you all the best. Do well in your exams. I do hope each and every one of you clears and gets a really good rank. All the best for your future. I think we can close now.